So you never get a second chance to make a first impression. I always like that as something to remember. Head and Shoulder shampoo was really a very common shampoo a long time ago. Now nobody's ever heard of Head and Shoulder shampoo, but the shampoo's gone, but the saying it remains. And you'll never make a diagnosis that you haven't heard of. And I think those are two things that are kind of come up pretty frequently in medicine. And the bottom line is one of the things we do is we kind of keep on focusing on the same things. We get the asthma, we get the chest pain, we get the belly pain. But out here on the end of the bell are things like that are important, rarely seen, but you got to make a diagnosis on the first visit to the emergency department, and we'll talk about some of those diagnoses shortly. So many of the emergency departments, this is the first approach that the patients see. That it's about a 2-inch thick lucite, and they have a little thing there like you're going to the movies. I'll take 2 tickets to appendicitis, please. And it is certainly unfriendly, I think, but it's kind of like, well, we're afraid of the patients. We think they're going to blow us up, and so that's the kind of thing that we have to have, because obviously we're afraid of them. You go into the lobby of the hospital, front lobby, with the big donor wall, and they don't have anything like this, but this somehow the ER is kind of like a dangerous kind of place, and so this is what every patient sees this. And then we'll get you to the triage nurse, but this is usually the first thing we see, which I think it makes a bad impression. Already, I think we're starting off on the wrong foot when you do something like that. I think most people who come to the emergency department have some level of anxiety, and they're fearful, and what's wrong? Is it serious? That kind of thing. We tend to get sometimes a little callous and think like, oh, you here again kind of thing. And the idea is that there's all of these repeaters, and this is an emergency, and you should go to the urgent care. Did it. Well, the fact of the matter is that 80% of the people who go to your emergency department go home. They have relatively minor things that they go home with. And if you basically think all of those people should be someplace else, then your emergency department will close, because you cannot deal with just the patients who are admitted. So 20% of the patients are admitted, 25% of the patients are admitted. That's the national average. If you want to see only the critical cases, that's the cases you want to see. And that 80%, you're going to let them be seen by an urgent care or somebody else. Then you will close, because those 80% help support the fact that the ER exists at all. I think the idea of creating a positive experience is one of the goals. They assume that you're going to do good medicine, but the idea of creating a positive experience, so that they say, they were really nice to me, they answered my questions, and they made grandma feel pretty good. That is another goal, and that goal should be actively sought by the department. So there should be policies that make it clear that we're going to treat people the way they want to be treated, and then that's the department has policies. And then you, as a provider in the department, are going to say, I understand that, and that's what I want to accomplish too. And so between the two of us, we're going to accomplish the goal of having good medical care and a positive patient experience. And now, obviously, all patient experiences clinically will not be positive, but we're going to do the best we can to make people feel comfort in these times of anxiety and grief. I think everybody ought to be I believe that this is a modest proposal, but I think that every 5 years you ought to have an organ removed. I think if you have an organ removed, that you'll be on the other side of the bed rails and see what it's like to be a patient. Now, you can't be a patient in your hospital where they know you and they're going to give you special attention. You have to go to some hospital where you're not known, and you have to have an organ removed. Like, you don't need those tonsils. I mean, what do? Just take those tonsils out of there. Gallbladder, it's a waste of time. Get rid of that gallbladder. You women, 45, get rid of that uterus. It's just trouble. Get rid of that. You don't need it. And you get to see what it's like to be a patient in the hospital. It's so easy for us to stand vertically on the side of the bed rails, but these other people are like horizontal. They've lost all their power, kind of thing. When they're lying horizontal, they're in a gown that doesn't cover their tush. And so it's kind of like not a really very positive experience right off the get-go, unless you are saying, Can I get you a blanket? Do you need something for pain? How are you feeling now? Does the medication help any? We're waiting for your call back from your family doctor so that they know what's going on and they feel good about what you're doing in terms of your interaction with them. Yeah, this is the idea of the department of process. You have to have a department that is kind of like enlightened. I don't know, some of you probably do have enlightened departments, and I'm sure some of you don't have enlightened departments. And it'll be very clear what an unenlightened department is as we go through this. And so there's a department job, but there's a job for you. Your job is, I'm going to go into work, and it's not just about the medicine. They assume that you're going to do good medicine. They have no idea whether they needed 3 CAT scans or how much blood work or do you need tox pad or anything. They have no idea whether that's appropriate or not. The more the better, keep on ordering kind of thing. So they're not a good judge of the quality of the care that you provide, but they are a good judge of the quality of the caring that you're providing. And you basically want to be considered to be one of the people that the nurses feel really good about in terms of this is one of our clinicians that is really nice to the patients. He makes them feel good. My mom came here. I would want this person to see my mom. That's quite a compliment to you, for you to render to some other of the people who work in your department. This is our reputation right there. If you ask everybody, they say, well, I'm glad we have these ERs, but they make you wait. And on top of them making wait, it's kind of concierge level service supposed to be, because the average bill out of this emergency department is going to be $1,200. No matter what the heck's the matter with you, it's going to be $1,200. So that's concierge level payment, but we don't give necessarily concierge level service. So all of these ERs are trying to show up that we can do it. We'll give you good service. Here's the waiting time. And they somehow have some of these apps, some of these billboards have the numbers saying here's what the waiting time is. Yes, sure. But they all recognize, but we all know, that people complain about the wait in the department, and I think that's true. And some hospitals don't make them people wait, and other hospitals do make people wait. And I think that it's kind of like the most important time in the emergency department is the door to clinician, not the door to triage, the door to clinician. That's door to you. So if it's 15 minutes, that's great. 30 minutes, okay. Anything over 30 minutes, door to you, is not good. I think you need to practice sitting in a room with Oprah Winfrey on television, watching for half an hour. Do that for half an hour, and see how you think whether that's a long wait or not. I think for most people that would be considered not a short wait. That's for sure. So waiting time is really about how you value people's time. If you don't value people's time, you can make them wait. Value people's time, you'll get them in and out quickly. And this is all about from the top down. CEO wants to happen. If the CEO wants short wait times, there'll be short wait times. If the CEO wants to get rid of holding patients in the department, they'll get rid of them. So this is a top-down process. It's very difficult, bottom up, to say, please, let's get these patients out of here. The CEO has to have this mindset about the importance of the emergency department in terms of the community. More people experience the back door, your door of the emergency department, than the front door of the hospital. So you are basically giving the community here's what our hospital is like. They come through the back door, which is not with the plastic chairs in the lobby, the bulletproof lucite for the clerks, kind of thing. So I think we often make a very bad impression. So this first time is certainly important, the door to provider time. No, I don't think there's a more important time than this. Provider is not a triage nurse. Provider is you, PANP physician. So there's some ways that people get around that. They put a provider in triage. That's a good idea. That's one idea that's been shown to work. Or they put a fast track where people have minor things kind of can go into the fast track, and they don't have to wait behind all of the other cases that are going into the main ER. And some of these systems have been shown to work really very effectively. If the idea is to get a provider in triage, he can basically, or she can say, okay, let's see, these are 4 or 5 minor cases. They have some private rooms to see those 4 or 5 minor cases. And no, I think you need to go in the back, but before we send you there, let's get some stuff started. We're going to do this, that, and the other thing to facilitate your care in the back. So I think some people, and I would agree, that the smartest doctor should be the doctor who's up in triage. Not the doctor who never met a test that didn't like and orders every test in the book. Not that doctor. He doesn't go, you're not entitled to go to triage. You have to earn triage. So there are ways to do this, and some places do it really well. So you have to have your own sense of urgency that the door-to-doctor times matter. And you can get that started just by saying, hi, I'm Dr. Bukata. I'm going to be seeing you. I understand you've got some problem with X, and we're going to get some stuff started. I'll be back to examine you more and talk with you more thoroughly shortly. So that's, a really quick, in the door, hi, saw the doctor, cool. And then you have to write that time of contact down, because some places, they make the time of door to contact is the first order that you enter into a computer, because there's a time on that order. Well, that obviously is not the correct time at all. And in fact, it's much longer than the time that it took for you to see the person. So a simple greeting, that's all they're looking for. They're not looking for, just say, I acknowledge that they're there, and never go in and say, what's the matter? I'm here, what seems to be the trouble? Well, that seems to be a nice start. What seems to be the trouble? Well, I told the trouble to the triage nurse. I told the trouble to the nurse who's working in the room here. And now that you're the third person, doesn't anybody read the chart, kind of thing? So don't ask that. Don't say, what seems to be the trouble? Take a look at the chart and say, I understand that you have some X. Because 2 other people, put that stuff down. There's a list of times that CMS is basically saying we want to collect to see how good you're treating the Medicare patients, and by extension, all the patients in your hospital. Because we're paying a lot of bills, we want to see what the service is like. So we want to see what the door-to-doctor time is. We do want to see what the length of stay in the emergency department was for. They did want to see what the length of stay was for discharge patients, but I didn't think that they honestly, although it says it there, I think that they were not measuring door-to-admission time. And that's for certainly something they should measure. I mean, you're holding patients and they've been there 8 hours to be held. We should tell CMS that your hospital is dysfunctional, and CMS has got to do something to help your hospital here. Shouldn't happen. There's all these kind of things that you can do to get patients out before noon. Get the medical staff on your side to kind of get these patients out. So lying around in the hallway, next thing you know, you're examining patients in the hallway. It looks like chaos kind of thing. And oh, by the way, the bill's $1,200. So there's a bunch of times here what happened to this slide? Oh, this slide is about patients who go to emergency department sort themselves out as belonging in the emergency department. Because, if a person goes to a family doctor with some chest pain, more likely than not it's going to be GERD or something like that. If somebody goes to the ER with chest pain, it's not less likely to be GERD, it's more likely to be coronary artery disease. A family doctor, how many times have a family doctor seen a subarachnoid hemorrhage headache? Those headaches sort themselves out and they go to the emergency department. So the worst things in terms of these clinical entities are in the ER. So we, by nature, become worst first clinicians. And so if we can exclude the worst things, the more minor things, okay, we can deal with them. But by nature, we're worst first. And one of the problems with that is we tend to order a lot. and maybe our colleagues in their office setting say, you order, Cat's-Gun in every headache you see, kind of thing. Well, they don't see subarachnoids. We do see subarachnoids. We see intracranial bleeds. They don't see intracranial bleeds. And so it's kind of like the patients sort them out differently. Yeah, we did this one already. Yeah, showing you care is not optional. It is part of the job. I was the director of an ER for 25 years in Los Angeles, and so you would hire a doctor, and you would assume number one, the doctor was clinically capable. He knew the medicine. Knowing the medicine is difficult. I mean, it's a lifelong career learning the medicine in terms of experience, and I've seen these before, I've not seen these before, that kind of thing. So knowing the medicine is not easy, but it is number one. Number two is making the patients happy. Now, for many clinicians, that pisses them off when I say that, because they said, well, I found a problem. I'm a good doctor. I took care of it. But it's also part of your job to make the patients happy. We don't want any complaints about your behavior, because where will that complaint go? That complaint will go directly to the COO. And the COO, as soon as it gets that complaint, will be giving me a phone call. We'll get some complaints about Dr. So-and-so in the emergency department. That needs to be fixed, because if it's not fixed, there's the issue of maybe we should change contracts, because this doctor, this director's just not doing. The ER people work for the COO and the CEO. We work for them. Those of us who are independent contractors, we work for them. So showing you care is not optional. You just basically got to get your game face on and do it. And it doesn't matter whether you want to do it or don't want to do it. You got to do it. Most of you hate the idea of Press Ganey, and I don't think it's a great idea, but Press Ganey isn't easy. It's an open book. So you take the Press Ganey questions and stick them in the doctor's room, wherever they are, and say, well, they want you to introduce yourself. And they want you to basically address the patient's privacy, and they want to make sure the patient has pain medicines or something like that. Well, you just do those things and say, okay, hi, I'm Dr. So-and-so. Just remember that, will you please? I'm going to close the curtain for your privacy. So, okay, I'm going to get that survey, Oh, yeah, he did say privacy. In fact, he shouted privacy at me, kind of thing. So you play the game. They want these 8 things done. You do the 8 things. You can't go playing the game if you don't know the rules. And the rules are, they'll tell you what's being surveyed at your hospital. I used to think that the looking the part was really super, super important. But studies say, it's not, honestly not. I was of the school where, the white starch lab coat with your name on it in the emergency department, that was kind of all our doctors wore ties, and that's the way we did it. And people in scrubs that was okay at night, but during the day, we wore ties and the white shirts. We looked like the faculty, and the faculty at the teaching classes. We looked like the faculty. But studies have shown people, they don't really care that much. It's more about your demeanor in terms of how you behave. They don't want you looking sloppy like you slept in those clothes for 3 days. Sure, and the lab coat you're wearing is got stains all over it. They're not interested in that. But people talk about nonverbal communication and how important it is, and that in fact it relates to conveying more information than the actual words. So there's this is some options, and there's not one that's really the one. I personally like the one with the white coat, but it's not necessarily the one for everybody. I think as an older person, not that I am, but I mean, if an older person comes in, I think they like the white jacket kind of thing. It makes it clear who's the leader here of the band, but that's not the case in other places. This is the chart that I found about nonverbal communication. I don't know if I believe this, or to tell you the truth. I think appropriate touching is a great idea. I think these people come in, they are a little scared. They are a little frightened. What's wrong with you? Is it cancer? You know, I get this pain. Is it cancer kind of thing? So a little touching on the arm, on the shoulder. Older lady comes in. It's okay to, just hold her hand while you talk to her. It basically is making clear, I'm here to help. I'm with you. I'm going to take care of you. That's kind of the message. Qualified translator. That's a good idea too. Qualified translator is not the housekeeper. Qualified translator, CMS mandates that your hospital has a qualified translator. Now, the definition of qualified is very vague. It's not a certified translator. So the fact of the matter is that you can have people who qualify at your hospital. But you got to be careful. You can't use a 6-year-old kid who's translating for the mom. Because what does a 6-year-old kid know about translating any of these concepts back and forth to mom? If that's your choice, that's kind of a dangerous choice, because when things go bad, it's going to say, what, you used a 6-year-old kid to translate for the mother, and now look what happened. So take the time to get somebody qualified to translate. The first thing you say to the patient after, I'm Dr. So-and-so, the second thing you say is, I'm sorry for the wait. It doesn't matter what the weight was. It doesn't matter whether there's any weight at all. The idea of saying, I'm sorry about the weight, means that it sends the message to them that I am your servant. I basically are providing you service. And it shows that you have some courtesy and that you value their time. It's a real quick way to send a very powerful message. I'm sorry for the wait. You can say, no, wait. That's all right. You already got the credit for it. All these people say you're asking history within 15 seconds. You're interrupting. Give them a chance to get a minute out. Give them a minute, then you can interrupt all you want, kind of thing. They don't like the idea of you looking up references in front of them. That study showed that. So it's like, what pill is that? I haven't heard of that pill. Let me look it up in one of these things that Martha just told me about. Don't do that. Look at the pill up at the desk. What's happening to our slides here? Okay, the other thing that they expect you to do is that you're going to touch them. I know, I have a friend who's an orthopedist. He went into the ER that I'm affiliated with. This was in the last 3 months. Went in twice for something that was potentially serious kind of thing. And I live like 5 minutes from the hospital. I met him over in the emergency department, and it was like, have they examined you? And this doctor said, they didn't lay a hand on me. They didn't lay a hand on me. They thought I had a stroke kind of thing, so they were going to call the stroke team to determine that they're going to do all the quick, do that, do this, do that, and nobody touched him. Turns out his EKG showed a trifascicular block, first-degree AV block, and he basically had like a half a wire running his heart. He was sitting at the table, and all of a sudden he passed out. All of a sudden he wasn't there. His wife noticed it. What is that? That's a cardiac event. That was either asystole or a VTAC. Well, in his case, it was asystole. It was easy, but the fact is that nobody touched him. Nobody examined him. I saw the EKG. Other people saw the EKG. So the idea is people expect to be touched. They expect to be having an exam done. They expect that you listen to their chest or belly, and frankly, even if listening to their chest or belly means nothing to you in terms of what it's going to provide, they're going to say, Doctor, appreciate it. You did a good job. Especially in kids. Kids, you got to examine a kid's only that big. You can examine the entire kid in 30 seconds, and we'll talk about that more specifically when we talk about kids. But the idea is, after you're done, they're supposed to say to you, Doctor, do you have a private practice? As soon as they say that, you have hit the ball out of the park in terms of they want to come to you, be your patient. Wonderful, wonderful, wonderful. And then you say, what, are you serious? private practice, you know. I like this thing about asking if any pain. Asking about any pain is almost like, I'm sorry for the wait. Asking about any pain, you know, puts that up front. Now, unfortunately, we're not allowed to give out any pain medicines anymore in the emergency department. So there we have the pain opiate-free emergency departments and all that other stuff. But I do think rapid relief of pain is a reasonable thing to do, whether it be an ice pack on that broken ankle or some, 6 milligrams of morphine kind of thing. I'm not concerned about addicting anybody with 6 milligrams of morphine in the emergency department. It's what you send them home on that gets them into trouble. They all want to know, what's the plan? Well, we're going to do 3 CAT scans, 2 ultrasounds. We're going to get a lot of blood, and in about 6 hours, all that'll be back, and we'll check you over again. So they want to know the plan. You tell them the plan as best you can. Coming back and reassessing them every 20 minutes. Every 20 minutes, I'm going to come back, see them. How you feeling? Does the pain help? Is the medication helping at all? Your tests are pending. I spoke to your family doctor. They want to know. 20 minutes is not an unreasonable time. And if you have helpers, like you have, scribes, or frankly, if you have a PA or NP helper or anybody who is helping you, that makes that all the easiest. The doctor, can my child have a CT? The child doesn't need a CT in this case. So what do you do in terms of dealing with when they're making requests that you don't think are appropriate? Well, you basically have to have a strategy to deal with that. CTs to the head are probably at the top of the list kind of thing. And so I basically warned them, Mom, there's a lot of radiation with CT, and it's been shown, truthfully, Mom, and there are studies that show this, the radiation of the head, to the extent that they get when they get a CT, it can be a long-term effect on their learning. So I'd rather not do this. And if Johnny was my son, you're going about to play the ace. This is playing the ace. If Johnny was my son, I wouldn't do it. I wouldn't do it. So that takes them into your confidence. I'm not treating you like all the unwashed mass out there. You're special. I'm going to tell you what I would do. So you say, I wouldn't do it. And if we radiate him, he's going to come out dumb, and you won't have to worry about paying for college. Privacy, I think, is important. You see this guy walking down the hallway all the time with his butt showing the IV bottle. Signing out patients. One patient's going to come. You got a new provider coming on now. How do you do this? Well, it's really simple. You take the new, whatever it is, doctor, PA, NP, who's going to be replacing you, and you go to Mr. Jones's bedside, not to the chart rack or you go to the bedside and say, Mr. So-and-so, this is Dr. So-and-so. He's going to be taking over for me now. He understands what we're waiting for, that we're waiting for the CAT scan and that we're waiting for a call from your family doctor. He knows what's going on, and he's a terrific doctor, and he's going to be taking care of you. This is. So basically, try to convey that you have some confidence in this doctor. It's okay. I mean, if this doctor then leaves the room, you can say, he's a really good doctor, something like that. Or he's a criminal. No, I mean, it's a good thing to give them a sense of he's going to, just like I'm taking good care of you, this guy's going to take good care of you too. He's one of my buddies. And he knows what's going on. That's where you do it. It's not at the chart rack. God, don't do that. And the next thing you know, the patient laying there and a new person comes in. Oh, your other doctor left. I'm Dr. So-and-so. Huh? Is that the way you would treat a patient? No. He's off duty now. No. Terrible. Absolutely terrible. We're going to stop here. This is the only survey that your CEO cares about, actually, other than your Press Ganey scores. Actually, this is the HIP score. And basically, about 20% of patients who are admitted to the hospital are asked this survey. And this survey results are on hospital.gov. Something or other. It's listed there. So anybody in the world can see what the ratings are of your hospital. You get like up to 4. I don't know if there's a 0 rating, but there certainly are ones. And so everybody can see whether you're a 4, 3, 2, 1 kind of thing. And so this is what determines what the world thinks of your hospital. I don't think it's a very good survey at all, frankly, but a lot of the questions that they ask patients who are admitted apply to doctors and the care rendered in the emergency department. So you should be aware of this survey so that you're aware of what they're going to ask on this national survey of 20% of every person who is admitted. So you're part of this, and so you want to help the hospital get a good score. All right, we'll stop here. That's pretty much enough of the preaching for a while, and now we'll do something more clinical. And my friend, Diane Birnbaumer, is going to do that.
I am.
Diane is the associate director of this endeavor, this boot camp thing that we've been doing for about 8 years.
Yeah, since 2012.
17,000 people have taken this course, which I think really says something about the hunger that there was in the community for education related to emergency medicine, particularly on the PAMP, and primary care physicians who work in rural communities who come work in the emergency department.